Okay.
Hello, and thank you for joining us for today's Great Challenges live event sponsored by the Robert Wood Johnson Foundation. I'm your moderator for today. My name is Kavita Patel. I'm a physician and a fellow and managing director at the Brookings Institution and a practicing primary care internist at Johns Hopkins. And I'm really excited to have all of you here today for a very important topic. Not only has patient-centered care been much of our conversation, as well as shared decision-making and all the aspects of how we can improve the quality of our care around that, but as you'll hear from our esteemed panelists, there's been so many conversations about what that really means and what we can do to contribute to the conversation, which is right in along with our themes of the Great Challenges conversation. So without further ado, let me introduce our participants. Their bios and their backgrounds are much longer, so I'd welcome you to check out either their Twitter handles, their bios, and other details. But we've got Alan Spiro, who's the Chief Medical Officer at Accolade. Saul Wiener is the Vice Provost for Planning and Programs and Professor of Medicine, Pediatrics, and Medical Education at the University of Illinois at Chicago. And last but certainly not least, Susan Sheridan, Sue, is the Director of Patient Engagement at the Patient-Centered Outcomes Research Institute. So thank you, all of you, for joining us on this day when I know we're all trying to rush to make our December deadlines. And just getting into a little bit more of the practicality of how what patient-centered care really is, I want to kind of get you started with taking time for each one of you listening or watching us, or those of you on social media, to think about the following. Have you ever had that moment when you left your doctor's office or left any sort of clinical setting and can't remember all the instructions you were given? Or you get to the pharmacy and your prescriptions were too costly so that you decided not to get them filled? Or if you're on the provider side, seeing patients who weren't necessarily as compliant and you're trying to figure out in 7 minutes or less what happened, well, that's what we're talking about today. Patient-centered care and patient-centered clinical decision-making. The act of collaborating with a patient to understand their unique needs and their goals while preparing a care plan specific to their diagnosis and needs. We'd like to, as usual, in theme with our Great Challenges here at TEDMED, we'd like to try to get as many questions and dialogue going from all of you on social media. So just use hashtag Great Challenges and we'll answer as many as we can today. Now let's get right into it. We don't have a lot of time and we like to keep everything as close to the exact time as we said we would. So let's start. If you don't mind, Saul, I'd love to start with you. You've had an amazing research career where you've looked at the role of contextual errors in clinical care. Would you mind describing that a bit and giving our listeners and viewers a sense of what that term means and how that has really aided and contextualized some of the recent discoveries in medicine?
Thank you. I think it started for me personally years ago when I was supervising residents as an attending physician in primary care. And I noticed that the young physicians were getting better and better at knowing what the guidelines are for things, at the research evidence, at the protocols. And that was, at the time, really a tremendous area of emphasis, the so-called evidence-based medicine. But one of the things that I also noticed is that there seemed to be something missing when a patient was presented and a set of guidelines were proposed. And often when I would go in to see the patient afterwards and we'd start to get into a conversation, things would come up that would lead to more questions. And all of a sudden, a story would emerge. That person had lost their job and they couldn't afford the medication. Or they had competing responsibilities and the plan of care simply wasn't going to work for them. And the excellent plan that looked so good on paper would start to sort of fall apart. And we'd have to construct a slightly or sometimes dramatically different plan that took into account these contextual factors. And that's when it sort of became clear that someone had to kind of label this phenomenon, and it became clear that this was, in essence, a kind of error. That we've been talking so much about medical errors, which are when you give the wrong drug or when you amputate the wrong leg. But when you come up with a care plan that looks perfect on paper, it sort of follows all the guidelines, but it isn't going to work for that patient. We've referred to that as a contextual error. Okay,
great. So, and Saul, I know we're going to want to do some follow-up with you on that because I think not just the phrase contextual errors, but especially kind of where you had, it sounds like the bulk of this being informed by just your practical patient care is a pretty important aspect to our new and changing world of healthcare writ large. So let me just shift to Alan for a second. Alan, you actually had a really interesting TEDMED blog that I got to read, and I would encourage others, if you haven't gotten to it, to go to the TEDMED page to look at it. And it talked a little bit about your group, Accolade, and it in my humble opinion, it kind of really talked about doing something that I think we all like to think we do in healthcare, which is linking patients better to the resources around them. But ultimately, as we've seen from so many studies, we really fail at doing this. Can you describe, just maybe take a step back for those who haven't read the blog, can you tell us a little bit about what that means and what Accolade does, and how that's informed in terms of what you've been kind of passionate about in life, how that's informed your vision and how you see healthcare moving forward?
Definitely, thank you. Really, what it comes down to is that people get sick, they deal with illness not in a vacuum, but as people. And people's lives are complex. And Saul's research has been just so earth-shattering, if I can use that term, in showing that in a more rigorous way. But for Accolade, we got started over 6 years ago, and we wanted to build a company that took a different view of what I'll call traditionally care management. And I have to admit to hating the word management. No one gets managed. So we started with the person back, with the consumer back, and we said, what do people need? What do people want? And the more we spoke to people and ran focus groups and did research, we found they needed help through a complex system. They needed help with balancing all the demands of their life and their family's life when they had to deal with illness. And they also needed help not just for themselves, but with their family, because healthcare decisions are really family decisions. They're not individual decisions. It's been said that the most important healthcare decisions are not made around a conference table in Congress or a board table. They're made around the kitchen table. And we wanted to really impact that kitchen table. So in looking at that, we found that what was really needed at this point, because much of what we were talking about in a simpler time may have been done by a primary care doctor, but in a time in which that primary care doctor's time is pressed, when there are so many life stressors, and when the benefits are so complex as well, that we needed a new profession. And in a sense, we started what we call the profession of health assistant, to bond and form a relationship with a person, usually telephonically, to spend as much time as needed to help the person get through the minefields of healthcare while they're also balancing all aspects of their life. And it's been successful.
So I already have my own questions that I want to get into about that. I think that's very exciting. Both Saul and Alan, just kind of almost the complementary views you from not just the practical and research side, but then Alan, very exciting. Like even in just the last 6 years, what you're building upon, and hopefully can grow more and more. And I'd love to now turn to Sue. Sue, I've had the luck of knowing personally and prior to her leadership role at PCORI. But Sue, I would imagine certainly since your time at PCORI, which started literally, from the Affordable Care Act, and has now really, I think, emerged as a true intersection for the kinds of research that Saul described, as well as the very important patient perspectives that I'm sure you see on a day-to-day basis. So can you tell us a little bit about your time either at PCORI or even before, where you've seen kind of the patient's point of view and that intersection with patient-centered care and the research, and where you can see that going?
Sure. As you can imagine, I hear stories daily from patients around the world via email and phone calls about exactly what we're talking about today. And, in these conversations, what patients bring up are those what ifs or if onlys. And what they're bringing up actually are research questions. And so what PCORI looks at this is to really get good patient-centered care, we really have to have really good patient-centered research. And what that means is inviting patients into the research world to design research that will ultimately design information that matters to patients. So it's like bringing what our other speakers are talking about, making healthcare real and meaningful, and giving them information that matters to them, looking at their life and how they are. So again, it's this nice combination of patient-centered research that leads to patient-centered care, and infusing the experiences and the wisdom and the determination of patients in the redesign of all this.
So Sue, thank you. And actually, let me just do a little reminder that if you've got questions, we're getting questions on various forms of social media, but certainly if you can, hashtag Great Challenges, and we'll make sure we pick up your questions in all the different formats, Google+, Twitter, Facebook, etc. So please let those come on in. And we already have some questions for our panelists. And actually, Sue, let me pick up on something you touched on, because you said that you're hearing from patients all the time. It's interesting, we hear from like Tracy Moran and some other leaders who have talked about how little time clinicians have, and I kind of referenced the 7 minutes that I have with a patient. That's become the common refrain. So what is it? And sometimes I worry, oh, I just don't have enough time to do kind of shared decision making, or the kinds of things that I think Saul and Alan and you have described that we could do in healthcare. But how can, whether it's PCORI's work or this emerging field of like patient-centered research that we're taking to a practical level, how can we help that 7-minute clinical conundrum, and where do you think we can make progress?
Right, and that is a reality that we have to appreciate, and that we can't expect everybody to spend all their time doing shared decision making. So it's something that we envision is that in this patient-centered research that's providing tools and information for patients, that's meaningful, that's relevant, that matters, that we need to get that information into their hands before the patient-doctor encounter. So something that PCORI is really looking at is how do we disseminate, how do we share this information through pathways, creative pathways, that is through, that's culturally appropriate, that is accessible, that is through pathways that real patients use. We don't pick up peer-reviewed journals. And so we need to learn how to better get this information, equip the patient before they go into the encounter, because as we know, information is power. And so we want to give that patient more power, more focus before they meet with the doctor, and then I think they can really spend that 7 minutes or 10 minutes, whatever it is, to be far more productive and really talk about the different options, because that's what patients really want depending on their life. They want to look at options that are going to help them get the outcomes that are important to them.
So let me, Alan, I think you wanted to get a comment in, and just to tee you up, I wanted to get your comment in, Alan, but then also ask you a question that's coming in around whether or not you've had any economic data for the model that you've described in Accolade. So go ahead and get your comment in, Alan, and then ask or answer the question around any data you might have.
So my comment was around Sue's point, which is so important, that you have to get to people before care is rendered. And our approach to doing that is we actually take over the 800 number on the back of an insurance card. So we fulfill those member services functions, because what we found is that people call that number to find out what their benefits are, to find an in-network provider. They call that number, and 2/3 of other relationships we form and how we help people is before care is rendered. And we do then are able to give them the questions to ask the doctor, even in written form, and to tell them their options before that care. So that's a very important piece. It also relates to your question on the economic impact. We've been successful as a company thus far because what we say to the financial risk taker, large employers for the most part right now for us, is that we don't want to be paid unless we both delight your people and save money. And we found savings of around 8% without shifting cost to patients, without doing any of what I'll call the more draconian design issues, just on the basis of helping people through a complex system.
That's a great, I think we're kind of dancing around it. One of our questions on Twitter is from George, and I'm going to hopefully say his last name right, Margelis, who asks, and Saul, I'll kind of ask you this question because I think your research has informed some of the answer to this. Do we still need to physically be in the room with the patient to deliver patient care? And how can electronic follow-ups or the field of kind of e-medicine really help us to do some of this better?
I would actually say that you often don't want to be in the same room as the patient to provide patient-centered care because the patient would rather be somewhere else. Going to the doctor is a big pain. And the idea, one of the principles of patient-centered care is you get the right care in the right place at the right time. And so if you're a patient and you can get a question answered via a secure email, or if you can get a medical need met by having someone come to your home, or if you live in an area where there are no physicians and you can get a telehealth visit instead of having to travel somewhere really far and your needs are met, that's patient-centered. So I would actually say that a key aspect of patient-centered care is providing that kind of flexibility to patients so that they're not stuck having to drive to the doctor's office when they don't need to.
Great, thank you so much, Saul. So Sue, we've had a couple of questions on Google Plus as well as on Twitter. Patty Skolnick, whom I know you know, asked on Twitter, so how are we able to get clinicians to realize the importance of having a true relationship with their patients? And I know this is something you've spent your life thinking about and continuing to work on. Can you give us your sense of how we can kind of continue to get clinicians to realize the importance of this?
Well, I think it's a two-way street. I think it's a couple things. First of all, when I was at the WHO, we did some research on what did patients really want in terms of outcomes and their engagement. And we found that the majority of the world of patients really do want to be engaged in assuring good outcomes. But what they needed was an invitation from the healthcare system, or especially the provider, to be invited into the discussion and to really being part of the team. Now we know that not every encounter is going to come with an invitation to be an active patient, and so patients also need to start inviting themselves into this discussion and just being part of that team. And this is a culture shift, and this is something that we all need to come to the center from the top down and the bottom up to find this sweet spot where this is indeed a relationship. This is a long-term relationship. This is a trusting relationship where it's all based on the outcomes that are important to the patient. You know, the mantra, nothing about me without me, is really, that has lived over the past decade, and it's really a reality. It's not there's no easy fix, but it's this inviting ourselves as patients and hoping that the healthcare system will begin overtly inviting us into the discussions and engaging us as real partners in our care. We are the experts.
So let me shake things up a little bit. We've had some folks on Google Plus as well as other forums ask questions around reimbursement and how would changing reimbursement, any of the changing reimbursement models really help to drive some of this care. And I'll kind of ask this of all of you in different ways. Let me start with Saul, especially since you commented on how you first saw this when you were a practicing resident. Now that we've seen kind of newer models of care emerge, accountable care organizations, patient-centered medical neighborhoods, and this real focus on the patient, yet at the same time, some of this is really around changing the financing of care. Where do you see the intersection of how we pay for care and what we've been talking about thus far?
Oh, that's a really important question. As long as you're stuck with a fee-for-service model, every time you want to deliver a service, you have to figure out if there's a way to bill for a particular funding stream. And this creates tremendous impediments to innovation and to team-based care. Once you move towards a global or bundled payment structure where you're no longer worrying about how you're going to bill for a particular service, you're given immense flexibility. A great example of this, for example, is the community health worker concept. The community health worker is a relatively new professional actually, I shouldn't say, there have been community health workers for a long time, but there's been a lot of discussion about who exactly are they and what do they do and how do we pay for them. And broadly speaking, they're kind of the poster child for why you want to get to a payment structure where you're not worrying about how you bill for everything. The idea behind having a community health worker is you have somebody who is well known in the community, who knows who people are, who's trusted, who knows what's going on, and who has a basic set of skills that are appropriate to facilitating the delivery optimally of a set of services. That becomes possible when you're no longer worrying about how you're going to pay that person. If you're simply in an environment where you have to provide the best, most cost-effective care and you're assuming risk as a global entity, then bringing those people on board starts to make sense. You no longer worry about how you're going to pay them because you know in the long run they're going to improve care, they're going to make care more efficient, and ultimately that's going to help the bottom line. So I think that's, in the broadest sense, an example of how the payment structure is critical for innovation and for creating a variety of models of delivering care.
Alan, thank you, Saul. And Alan, especially with the kind of professional health assistant and overarching comments about how reimbursement can shape or influence that. Any thoughts?
Reimbursement always shapes it, and it always shapes it in a variety of ways. There's an old saw that there's 3 ways to pay doctors. You pay them to do more, and that's fee for service. You pay them to do less, and that's capitation. Or you pay them to leave at 5 o'clock, and that's salary. Having said that, the challenge is that a physician is a high-priced resource. And to Saul's point, you need almost new professionals, which is what we're developing, and you need new ways of providing highly personalized, contextually appropriate service that is also very sensitive to cultural needs, that is sensitive to a person's individual needs within the context of their world, their spiritual world, their social world. And that's needed. And unfortunately, and I say it's unfortunate because I'm old enough to have practiced medicine when it was different, when you could really get to know your patients. Unfortunately, it's a challenge economically for physicians to do all that. It really is because of that financial constraint. And I think that when I use, for example, the model of psychiatry as an example, in the managed care era, when I started in practice, psychiatrists, and I'm not a psychiatrist, I'm a gastroenterologist by trade, psychiatrists did therapy and medication management. They did it all. And today, for the most part, the psychiatrist is a medication manager because their price point on an hourly basis is too high for talk therapy. So we've got to almost acknowledge that reality and set up the right type of incentives and payment programs. At the same time, we have to get past some old baggage that doesn't pay for certain things such as telemedicine consults and doesn't pay for the kind of email interaction that's so critical in our connected world today.
Great, and we've got more questions, and each one of them take on a little bit of a flavor of some things we've already covered, and exploring them a little bit more. But one question from Emotive Storytelling, I love that name, handle. What are providers' plans to increase communication with patients to encourage behavior change? So and I'm going to take a first stab at this just because I've seen already in my primary care practice the intersection of meaningful use criteria and electronic health records forcing this a little bit. It's asking us to, every single visit, kind of asking for questions around depression and smoking cessation and some other habits. But then on top of that, I've seen more and more, especially as we're entering into the patient-centered medical home or accountable care organization, doctors are doing, I'm seeing my own colleagues and myself doing more things in continuing medical education around behavior strategies that work for weight loss, for example, or for increasing medication adherence in diabetes. And so while I think we're all still struggling, as Sue kind of pointed out, with that 7 to 10 minutes, I certainly think that there's an overarching trend to encourage those of us who never got the kind of training we needed, what I would call kind of behavioral economics or the nudge factor in medicine, to actually try to do that with patients. I don't know, Sue, have you seen some of what kind of helps to get both patients and clinicians the kind of better communication skills and the transfer of knowledge that they need to change behaviors?
Well, somewhat. I think we're still learning. I think that going back to what we were saying earlier is that exchange of information and that open communication via whatever mechanism that is, via email, especially using technology before the encounter. And so when you go into the encounter, that you're going in well informed, that you've had dialogue back and forth. We know that there's some clinicians and healthcare systems that communicate with patients well in advance of their meeting, and they're asking questions, they're giving them patient information in advance, so when they come to the encounter, it's productive and meaningful. So I think that through text messaging, we're seeing some new technology through that, and through email communication, that this communication is ongoing. It's not just a one-time when you see the doctor. This is a kind of a lifetime commitment that you're making to each other.
Saul, do you have, I want to ask you if you've got any thoughts about this issue around communication and what can improve that.
I think to get back to Alan's point, you sometimes get what you incentivize and what you measure. And one of the limitations in the way in which we currently measure and evaluate healthcare is that we don't really know what's going on in the black box that we call the doctor's office, the encounter, which is where the door is closed and a conversation is happening between a physician and a patient. We know what the doctor puts in their note afterwards. We know what the claims data shows. We also get information from the patient as to their satisfaction, what we call the patient experience. But we really don't know whether the physician, for example, is engaging in motivational interviewing when they're counseling somebody on smoking cessation. And if they are doing it, are they doing it effectively, for example? Are they just saying you got to quit smoking, or are they going through a change model? So I think a gap right now is in evaluating directly observed care. We are doing a quality improvement project at a VA, a couple of VA sites where I work, where we've developed a program that's actually based on research my team has done, where we have patients carrying small audio recording devices into their visits, and they audio record the encounters, and we tell them
All right, so we had a little bit of a technical difficulty, and I think there was a moment there where the Google Plus Hangout was actually getting powered by the healthcare.gov website. So we crossed paths, and I think that's why we went down for probably the last 5 to 10 minutes. But rest assured, we are hopefully back on, and all of you can hear us. So let's do a recap, just because I don't want to we were talking for a little bit and trailing while Google Plus went down. So let's just get back on top of it, and we're going to go for those of you who would love to kind of keep hanging out with us. Our panelists and myself are able to stay on until 3:15 Eastern Time, so we will not neglect any of the important discussion on this topic. But just remember that social media hopefully is still working, and you can send in questions, #GreatChallenges, and keep the conversation flowing. And let me just start with Saul. Saul, we've been talking and kind of talking about this intersection of research and its practical application, and kind of how can we make sure realistically that the work we're doing gets into patients' hands, and what are some of the interesting challenges around that. Can you tell us, in your experience, what you've seen and where you see some potential bumps as well as opportunities?
I think there really is a need for a culture change here, and I think one is happening. The past has been that, you know, if you're a researcher, you do research, and as soon as you've finished one grant, it's time to get another grant, and after you get that grant done, it's time to do another, and you publish your papers and so forth. And it's almost like real life and research is sort of in parallel universes, and the twixt are not meeting. And yet, you know, taxpayers pay our research dollars, and you know, if research isn't ultimately to help our patients and our health system, then, you know, what's the point? And so in our own work, we spent a number of years developing a process for evaluating physician performance at paying attention to patient life context. It's a very hard thing to measure. We've developed some metrics for it. We've been through a validation process. And essentially, we now have a quality improvement initiative where we have a lot of patients who are working with us to audio record their encounters. We're coding that data based on what's on the audio recordings. We're providing feedback to physicians with, you know, hard metrics about whether they're picking up on life context issues and addressing those in care plans. And the irony of it is it's hurt us. I'm part of a research group, and we are evaluated based on the amount of time we're spending on research, the funding that we're bringing in, and we actually now have the federal government, in this case the VA, paying for what we're doing outside of research because they actually think it's ready to go live. And the irony of it is that the research side, which pays our center, is saying, wait a minute, guys, you know, you're supposed to be doing research. Now, they recognize the sort of absurdity of that, and we have now set up a national working group to try to figure out how researchers can actually get credit for taking their work live, for actually bringing it to patients and using it to improve healthcare. But I think that's a process of transition that is just going on now.
So, Saul, just to follow up on that, does this pose we want to encourage, as Sue had kind of pointed out, patients to be involved in this, and to some degree, at least in when I had done kind of what we had been calling and still do call community-based participatory research, one of the challenges that I personally experienced in trying to do that type of research with a patient was that we also needed to kind of honor and acknowledge the amount of time we were asking them to devote to something. So in the work you've done, and in this migration, this irony that now they don't want to fund it as research, have you found that it's hard to continue to think about what can motivate patients to participate in that work that's important?
We found that patients are, first of all, they're understandably protective of their physicians. Many of them say, wait a minute, you want me to audio record this encounter? Am I going to get my doctor in trouble? Right. So we've actually put signs up in front of the clinic saying that that the physicians are welcoming in this opportunity. And we have built up over a period of years a lot of trust where the physicians understand that this data is safe. It doesn't go to their supervisors, it comes back to them. And then whenever we discuss it as a group, we discuss it in aggregate. And as soon as the patients understand that this is their way of helping make the healthcare system better, they're on board. They welcome that opportunity. We've been dealing with veterans who are a special group of people. As you know, veterans are a unique culture. And one of the things we wanted to make clear is that no one is ordering them to do things, that this is entirely voluntary. We invite them to participate. But I think bringing patients into the culture of participation in this type of work is something you have to do extremely sensitively. You have to make sure they never feel coerced. You have to make sure they feel that they're doing something that's valuable, not just for them personally, but for the system of care that they believe in. And you also have to make sure that you don't alienate the physicians, and in this case, we're actually not just evaluating physicians, we're doing it for the clerical staff and for the pharmacists and for everybody on the healthcare team. So it's a very careful culture change process.
Sue, how have you seen that in terms of, as you're describing kind of the patient-powered networks, and I hate to be so kind of tacky about it, but do you find that then when we're redefining roles as we're all patients, but when we take on a role as patient researcher or kind of patient advocate, how do you kind of some of the hurdles that Saul described, where patients don't want to speak poorly about their doctors, or they don't necessarily want to make a career out of research, but they want to participate? What have you seen that's successful?
Sure. Actually, I think what we've seen are two things, and Saul hit the nail on the head when he said that we need to invite patients to participate in research. A lot of patients have expressed an interest, and PCORI has done surveys that indicate that patients are interested in participating in research. They do want to see that it will benefit them or their community, and I think that's a responsibility of research to show that. And by embedding them and inviting them, infusing them into the research process, into defining the research question, into helping design the research, going out to the community and recruiting patients like them to participate in the research, we think that's going to create findings that are more relevant to the patient population. So actually we're seeing quite a bit of enthusiasm. Now, we are bringing two cultures together, and the research culture and the patient culture or community culture, and PCORI is creating some training tools and capacity building for both the research side and the patient side, but we're actually finding that it's not that patients and researchers don't want to work together, it's that they don't know how to. And we're trying to create this culture to merge these worlds and bring them together, and they all want better outcomes for patients. So we're actually seeing mounting enthusiasm about this kind of research. And there are sensitivities, and we do have to be aware of them. But honestly, and we're enthusiastic about what we're finding and hearing from both the research and the patient community.
Saul, did you have something you wanted to pick up on that?
Yeah, I wanted to say that I wanted to go back to Alan's earlier comment about how doing this in the real world, in the marketplace, is also a kind of research. I have to say I'm a little bit envious of Alan for having this laboratory, because really, it's just, in the sense, the proof is in the pudding. The folks who have put money down for Accolade were taking a gamble. Basically, they were saying, we're going to hire a bunch of social workers, if you want to put a term to it, and essentially say, go out and help people, and we're not even going to tell them to try to save money. In fact, we're going to tell them, if you think a patient needs more care, advocate for them. Just help coordinate things. And we believe that this is ultimately going to work as a business model, and so far it seems to be working very nicely. That's an extraordinary experiment. It's a big gamble. And I'm kind of envious because we've done some research in a very controlled way that shows that should be true. But we couldn't say for sure it was true. We've been able to cost out the errors that occur when care is not contextualized and show that it leads to waste. But that's not the same as actually doing it in the marketplace, and that's what they get to do, and it seems to be working, and that's kind of remarkable.
So, Alan, let me. It sounds like if you are hiring at Accolade, it sounds like all of us would be interested in doing. And one of my dear friends, Beth Toner, is one of the members of the team there. So you're already getting, I think, a world-class team. But can I press on you, Alan, to give us just even an anecdote or an example of you describe kind of this model and the returns you're seeing on the business side. Give me a kind of an anecdote or a tangible example about what some of the secret sauce is. Is it the professional health assistant going into the home? What does this interaction look like, and how are you seeing it produce a result that we can all understand a little bit better?
So first of all, we're actually, just to put it in context, we now have 500 employees, starting out with like 3 or 4 when I was involved in 4.5 years ago.
It's very smart of you to be one of the first 5. See, that's
Very good, that's right.
No one wants to be 1,000. It's great to be one of the first.
But what's amazing to me is that everything we do is not in terms of one encounter. Everything we do is in terms of forming a relationship with multiple encounters. So when you look at, for example, our health assistants who come at it with tremendous life experience as social workers, as nurses, as educators, go through our training, and Saul's absolutely right. We just say, do what's best for that person you're helping. And that's the only real rule. Help each other and help what we call the client. That's our term for the person who we're helping. And what happens is it's a relationship over time. The initial calls, to give you a concrete example, we had a man who we had a relationship with who had congestive heart failure, and he needed to go into the hospital. He clearly needed to go into the hospital. We couldn't convince him to do so. And it turns out that once we got to know him, the reason he wouldn't go into the hospital, and this was very intense over like a day, was because he had no one to feed his cats. We found someone to feed his cats, and he went into the hospital as was needed. People have to be seen in terms of their life. We had a person who calls us, and this is almost routine. We get people calling from the parking lots of emergency rooms saying, I have to go into the emergency room, but I need to know how much it's going to cost me. I'm living paycheck to paycheck. And we go through a quick triage, and often we find that we can get them to their primary care doctor rather than send them into that emergency room. But it's that where they are is worried about the money, and we can address that worry, but also get them the care they need acutely. So those are just a couple of types of examples.
That's great. No, I'm always amazed at how much we also ask a lot of questions now, especially with our electronic records around, kind of who's in your household. I've found that I've been more successful augmenting that question with, do you have, including any pets or animals? And it's been just awe-striking to me how many times people will say, oh, if I can't find someone to take care of my dog or cat or X or Y, I can't do that. And I often kind of pause and think, gosh, for like 20 years, have I just been missing this entire variable? And the answer is yes, I have been. I've been missing this entire complex interaction of, as you describe it, life. So I thank you for that anecdote. It kind of gives us a little bit of a reminder what we're all trying to work towards. So I know, so again, just as a reminder for those of you who were a part of the conversation where we had our technical glitch, we're going to go to 15 past the hour, so just so that people can continue to send us some questions in social media. And Sue, there was a question that came in, I'm not sure where, I think it was on Google Plus, from Amanda. Once you connect the dots, you have a line that will actually help address the needs of patients that can help the healthcare team of doctors, nurses, caregivers, pharmacists providing better care. But what is the first step a patient advocate should know and do?
Well, in terms of connecting all the dots and looking at this team that's forming around you, is to invite yourself in and make every one of those team members aware that you are part of that team and that you will be advocating for yourselves and for them, quite honestly, and your successful outcome. So the first step is to say, I'm part of this, and invite me in, and I'm a team player, and use me as a resource. And so that's a first step that a lot of advocates forget to do because they think it will just kind of happen for them. So, and also, a patient can really play a part in connecting all the dots and coordinating, keeping everybody connected and on the same page. So that's the first step out of the gate, to say, I am part of this team.
Yeah, okay, great. And then another question that I'm kind of summarizing a couple of other questions that people have asked around how there are pieces of the healthcare system that do these things. So we talked about social workers a little bit, we talked about caregivers a little bit. Maybe this is a question I'll start with Saul to see if he's maybe in his own examples, whether at the VA or otherwise, have seen this. Where have you really seen the kind of clinical world, doctors, pharmacists, the healthcare providers, intersect effectively with some of the other aspects that define, the 99% of our overall health. So whether that be education or other social determinants. Have you seen models or examples that really help bring that together for patient-centered care?
Let me see if I understand the question. Are you asking, am I seeing excellent examples of sort of the medical home environment where there's a team-based approach to care that is attentive to patients' needs and circumstances? Is that the question?
That on top of, I would say, the kind of work that even Alan had described, that, thinking about taking care of a pet, that would not normally fall into one of our conventional healthcare roles, so to speak, but sometimes takes the assistance of someone outside the medical clinic or outside the traditional medical building.
I think, well, first, just a general point, which is there's been this common paradigm that to reduce costs of care, you're going to have to cut care. You're going to have to reduce the quality of care. You're going to have to make care. You're going to have to provide less care. And I think one of the most important messages that comes out of, well, certainly Alan's story and also the research that we've been doing is that simply attending to patients' needs and circumstances reduces the cost of care, because so much of the waste in care is caused by misunderstandings, by redundancies, and so on and so forth. So I think that's just a general point that I just wanted to make sure I articulated. In terms of the cat story, being sensitive to someone's cat, I just want to give an example from my own clinic last week where a resident was frustrated because a patient who came in and had a toothache was insisting that he needed antibiotics for an abscess. And the resident said, I looked in this guy's mouth, his teeth are terrible, he needs to see a dentist, he needs all kinds of work done in there, but he doesn't need antibiotics. And all he's harping on is he wants antibiotics. And his wife is sitting there in the corner and she's not saying anything, and I don't know what to do. These patients are always so insistent that antibiotics are the solution to everything. So I went in there and I looked in the guy's mouth, and sure enough, there was no abscess. He desperately needed to see a dentist, and he didn't need antibiotics. So I started trying to explain this to the patient, and he got very upset and irritated, and he turned to his wife and he said, they're not helping us, let's just get out of here. And the resident saw this as kind of a frustrating situation where a patient just won't listen to us. I was curious. I said to the patient, I'm puzzled because we're trying to set you up with a dentist here. It seems like we're trying to be helpful, and you're saying you don't want this help, you want to leave, and you're frustrated, and I'm puzzled as to why. And the patient, who is this big, muscular veteran who had actually given me such a strong handshake, my hand was still hurting, he was looking at his feet, not saying anything, and his wife said, he's afraid of needles. And there was this dead silence. Afraid of needles? Yeah, he doesn't want to go to dentist because he's afraid of needles. So what's behind that? Well, it turned out in the 1950s, this guy was a child, and it was the polio epidemic, and they were giving polio vaccinations by using the same needle over and over again on these black kids. They were sterilizing the needle in a burning hot flame, and they stuck it into his arm while it was still red hot and it was dull. And he was so traumatized by that for the rest of his life he's been afraid of dentists. Okay, and he's not gone to the dentist, and he has a deep phobia of needles. Okay, and his mouth is terrible, and he had never said that before. And it only came out because I just kept saying to him, I don't understand. And finally his wife spoke up. Okay, I had no idea where this was going, but I was just pursuing the question. As healthcare providers, we have to ask questions. When things don't make sense, we have to ask. And that's the only way we ultimately engage. I think the most caring thing you can do for a person is ask them a question. And ultimately, because his wife was there, she opened up, and we realized what this guy needed was desensitization therapy through a program we have to help him get past this problem, so that ultimately this, desperate healthcare problem could be addressed. I don't think there's any one answer to that. I think that engaging with patients and figuring out how to contextualize care is something everyone has to do, and they have to be willing to ask questions.
And so, Alan, I think I know you've got some opinions and thoughts on that. Can you comment on what Saul talked about, and then in addition to that, also kind of this example, maybe from Accolade or maybe some other work you've been familiar with around bringing this exact issue together and to a finer point, kind of the cat and the narcotics and the fear of needles, and how we can bring that into that married to the delivery system in some way. So just first your reactions to Saul's comments.
So I've heard Saul say before that questions are caring, and it's something I steal from him all the time because it's a wonderful quote, and it's so true. When we train our health assistants, we train them to ask what we call the fearless questions. We tend to be almost too polite in our society about these questions, and sometimes you have to be what I'll call pleasantly persistent in questions to get at what's really going on with somebody. So that becomes part of our training. What you're really talking about, though, when you say putting it together, also relates to the extreme fragmentation of healthcare today. And it's a frustration for patients. It's a frustration for doctors. You know, the caring doctors who really want to be able to make a difference and to care for a whole family are frustrated as well, which is almost an existential problem for medical practitioners these days. And I agree with Saul. I don't have an answer. I think that what we're trying to do at Accolade with health assistants is one answer. I can't say that's the only answer. I think there's going to be multiple answers. And I just hope that we'll get those kinds of multiple answers being able to all fit in for certain segments of the population.
All right. Let me make sure I'm not muted. Good. So let's transition, and now I want to make sure I pay attention to time. I've got one final question for all of us to answer. So I'll start with Sue, and then I'll go to Saul, and then Alan, just so that you're all ready. Through this Great Challenges program, we've been able to focus on the fact that issues can't be solved with the silver bullet or a one-shot simple cure, and that we can actually certainly identify smaller, less magical ways, although I think some of what we've talked about is pretty magical, that can make a significant impact in the healthcare space. With so many critical issues driving the complexity around this topic, where are some of the best places to start focusing our attention? I know we've talked about this a little bit, but let me ask each of you to reflect and give us kind of a summary on where do you think, what are some of the things that we can do to start seeing an improvement in the short term in order to build momentum and gain hope for the future? So Sue, I'll start with you.
Sure. Well, and I have to admit up front I am somewhat biased about this, but I've been able to witness the patient-centered movement over the past 15 years, and I think one of the transformative components to better health care and better outcomes is getting the patient at the table when we're talking about the variety of different settings. And so getting the patient at the table when we're talking about improving their own care, getting the patient at the table when we're talking about improving healthcare systems and quality and safety, getting the patient at the table when we're designing research, when we're creating policy. And so I think patient engagement is one of the, I don't know if I'd call it the silver bullets, but the IOM, HHS, our government is all looking at, the real life patient experience as a real teaching tool in driving better outcomes and better health and health care. So I continue to believe that learning from the patients and getting them more infused into the redesign of our healthcare system, I think we will have better outcomes.
Great. Saul?
I think that we need to start measuring that which we care about but have not been measuring. And I think that requires the two methodologies that I've been involved with, which is you either have patients audio recording their encounters, or you send in incognito, unannounced, standardized patients and have them audio record encounters, and then you have rigorous measures of whether physicians are providing patient-centered care. And by that I mean, are they picking up on clues? If a patient has lost control of their hemoglobin A1C, their diabetes is out of control, is the physician simply saying, oh, we're going to give you more insulin, or is the physician saying, gosh, Mr. Jones, your diabetes used to be so well controlled, what happened? And then finding out that that patient had a major change, that they now have a job and they can't take their meds at a certain time, or they are developing cognitive deficits and they don't understand their medication anymore, or they have a competing response. The list goes on and on. Unless we start measuring that, which requires knowing what's going on during an encounter and having metrics, it isn't going to change. And so I think that's a key issue for us. Performance measurement has to include what happens during the visit in real time, and we have to have metrics for knowing whether care is in fact patient-centered.
And that, just to kind of, those metrics and that ability, sometimes when we talk about metrics, certainly people feel like that's really long-term, you know, we're trying to develop and refine the metrics. So just to reinforce, the metrics are available, we can do them now, and we don't need to delay. Is that fair?
Exactly. Okay. Absolutely. Right. And it's happening in places.
Exactly. Alan?
We are in an era of big data, of evidence-based guidelines, of population management, and within that world, we have to always remember that it's not patients, it's people. Each unique individual comes at their own and their family's challenges in health with their own values, with their own beliefs, with their own situations that every health professional has to be sensitive to. Everyone. And that is almost what I'll call an individual challenge to everyone in the health professions that I would just put out there, because that alone today would make a tremendous change. And I don't see our panel moderator anymore. So, yeah, there she is.
Kavita, we lost you for a minute.
Kavita? Looks like we lost Kavita. Oh, she's back.
Yep.
I was just going to say as a TEDMED moderator.
All right.
Jump in, but it looks like you're here. I'll let you close out the group.
I thought we would just keep it fun by having me just drop in and out. I'm keeping things exciting so no one stays asleep. Let me just close by saying, let me do one thing before I get to my kind of closing stuff that I need to do. One thing I want to add that I would kind of plea for all doctors or providers in general who are listening, something that's short-term is, and as you're going through your day and your routine of everything we do in clinical visits or in healthcare, try to kind of extend your thinking and just ask, what's one question that I didn't ask that I wish I could have? And I've tried to do this myself, and I'll do it like visit to the next visit and say, what was the one thing that I didn't get a chance to, whether I had time or not, and make sure that I try to reinforce that. And often that one thing is, did I just stop and listen to the patient, or something as simple as that? So I'll put in my own 10 cents for these. Don't have to be magical solutions that take people, passing laws in Congress, but they can be kind of simple, an N of one that can have an impact on many. So that's just my 10 cents on that short-term magic that we can do. So let me just say that I know that we had a little bit of technical glitches, including some of my own, but please jump on. We will have this up and this available for anybody who couldn't participate during this time, but get onto the community pages and have a say in keeping this discussion alive through all of our various media outlets. And then to build on this discussion, the next Google Hangout will be held on Thursday, December 12th at 2 p.m. Eastern, and we'll focus on transgender health. So we're going to continue with the theme of great challenges with this important topic next Thursday. And then thanks to everybody in the TEDMED community, our amazing panelists who get a round of applause, and our team members, and of course those of you who joined us today online, plugging through even our technical glitches. And then finally, thanks again to the Robert Wood Johnson Foundation for making this discussion possible. So goodbye, everybody. Now we're really signing off. Thank you.
Thank you.
Thank you.